coated. I thought he will next try platinum coated, but he stopped at Teflon coated. Next time, platinum coated only, or one of the patients will, I think, gift it to him. So I think we are now online.
YouTube started, ma'am.
Yes.
Yeah.
So I will just start off. I know it's a Diwali afternoon, but it's important that we discuss this topic because I and Dr. Padmapriya have decided that we will try and give our whatever little knowledge we have on obstetrics to everyone here. We'll share it with everyone because we enjoy doing obstetrics. I agree. I think Dr. Padmapriya also agrees with me. So today's topic is techniques of breech delivery. So malpresentations, I think now is a common indication for cesarean section. So after the term breech trial by Hannah, which was published in Lancet in 2000, it is now concluded that the outcomes with planned cesarean in a case of breech presentation is much more safer than in planned vaginal delivery. So I definitely don't allow breech presentation beyond 39 weeks to deliver vaginally. I do it as an elective cesarean, but the techniques of delivering the breech is same as in cesarean as it is in vaginal delivery. So the relevance of today's topic is that we should safely deliver the breech during cesarean by the following maneuvers. So I will tell you the breech. So breech can be divided into complete and incomplete. So complete breech is when there is flexion at hip and flexion at the knee joint. And incomplete breech can be either extended, that is, or frank breech, what we call, where there is flexion only at the hip joint and extension at the knee joint. It could be a footling presentation where the baby is standing upright and the foot is felt in the pervaginal examination, or it could be a kneeling wherein the knees are the presenting part. So these three are incomplete breech presentations. So sometimes what happens, one of the leg will be flexed and one of the leg will be extended. That still constitutes for an incomplete breech presentation. So in breech delivery, there are three modalities. One is spontaneous breech delivery, where the entire body of the baby is delivered without any efforts from the obstetrician. Assisted breech delivery, where the baby is delivered spontaneously till the umbilicus, and after aids in whole body of the baby is delivered by the effort of the obstetrician. In cases of breech delivery, so we divide it into three parts. So one is the delivery of the legs and the buttocks, delivery of the shoulder and the arms, and delivery of the aftercoming head. So we go one about do the delivery. I will show you a video as to what is which the patient for elective cesarean for a 3 kilo baby with oligohydramnios with breech presentation. So as usual, you can see that I am cutting the rectus, opening the abdominal cavity. And this, I think, is a standard practice everywhere. So here in breech, what I tell them beforehand is that I want them to keep one extra mop and keep a count. That mop will go along with the baby because I will use it to wrap. And here, as you can see, I am holding the UV fold and trying to cut. This step is not mandatory, but I like to do it. And when we incise, The lower segment, as we can see, sometimes it is well stretched and thinned out, especially in cases of previous cesarean. Care has to be taken not to incise very deeply with the knife, because nicks on the buttocks are quite common. And I have also come across where I have made a nick. So here the retractor is taken out once I once I put my hand inside the uterine cavity. So this is a frank breech, extended breech. So here I'm trying to hook my fingers into the hip, and I will just ask my assistant to give the pressure where the legs are delivered completely. So once the legs are delivered, so I bring the baby down just with gentle traction at the iliofemoral area, and I deliver the baby's hands, and then the baby's head. So here I will again go through these last two steps, because this is an unedited video, but still it is quite fast. So once I hook my fingers and get the legs out by my assistant putting pressure, I wait and put them up and cover the baby's back. The back has to be kept anterior always. Try to hook the baby's hands and bring it down on the face of the baby so that the hands are not stretched. So here you can see there are 2 loops of cord around the neck, but I don't disturb it. I just put my hand into the finger into the mouth of the baby and deliver the baby out. So here there are a couple of things which we need to understand. One is the delivery of the legs and the buttocks. So in complete breech, it is quite easy, wherein we are trying to just hook our fingers into the ankles and just try to bring both the legs down. So here the important thing to notice, you have to bring both the legs down together and then start pulling. Do not pull with one leg down. In frank breech, so if it is like this, then gently we can hook our fingers into the iliofemoral junction and gently take out, or with traction and with fundal pressure, we can get the baby's body out. So this is important because in big babies, the traction itself or the fundal pressure itself may not be sufficient. Both has to be done simultaneously. And once it is done, so we just try to bring the back anterior. So this is one of the most important steps which I follow all the time, that I want the baby's back to be anterior in majority of my cases, unless it's a very small baby. So keeping the back anterior or upwards, I mean, I will just check where the hands are. So the hands could be either flexed in front of the baby's chest, which is quite easy to deliver, wherein you just bring the hands down like this, or it could be just extending up near the head, where you have to bring it down, sweep it on the face and bring it down.
Madam, is the transmission okay? 1 minute, madam. Is the transmission okay?
Then either but again try and sleep. It's not coming. You think there is a?
There was a little bit of glitch in between, but now I think it's okay. Yeah, just
Interruption?
Yeah.
Dr. Shilpa, I think you had lost network in between, okay?
Yeah. Shilpa ma'am, there was, when you were delivering the breech, no? I think we lost network. Yeah, not the videos. Now in this in the dummy, ma'am. Ma'am, I think we're losing network.
Dr. PP, can you continue till Madam joins back?
She has the dummy
Yeah.
with
Yeah,
Yeah.
can you hear me, Dr. Priya?
Yeah.
Yeah, is it better
Yeah.
now? The transmission
Yeah.
better? Okay,
Yeah.
sorry. So, as I told, if at all, if the baby's hand is behind the baby's head, then we can see the winging of the scapula, and we have to make an effort to bring the baby's hand, sweep it over the face, and then only deliver the hand. So even the opposite hand should be delivered like that only. Otherwise, there will be dislocation and also injuries to the baby's hand.
Exactly.
So yeah, next comes the aftercoming head. Okay, so I will show you another video and then I will go for the aftercoming head. So madam, can you see my screen?
Yes, madam. Yeah.
So this is another case where I'm doing an elective cesarean and I have incised. So this is not important. So once we incise the UV fold, so care has to be taken to note the presentation of the fetus beforehand itself, if possible, whether it is complete breech or whether it is frank breech, which can be noted by doing a pervaginal examination if the patient is in labor or in early labor or if cervix is dilated. So once I incise the uterine cavity, the liquor, I will not let the whole liquor completely drain out because I need some space. So here you can see that I am putting a slight fundal pressure to deliver the baby's buttocks. So you can see the buttocks are crowning and buttocks are gently coming out. So I want to hook my fingers usually to deliver the baby's legs. So you can see that the legs are out. You can see I'm sweeping the hand over the baby's face and then I deliver the baby's head. So in cesarean, usually if we can extend the incision, it is quite easy to deliver the baby's the aftercoming head of the baby. It is not very difficult as it is in vaginal delivery where there is space constraint. So delivery of the aftercoming head can be done either with Burn Marshall technique or with forceps application or with MSV, that is Marshall Smelly Weight technique. So I usually follow Burn Marshall technique, which is quite easy. But sometimes because in elective cesareans, the flexion is not great. And even when the woman is obese and the assistant, in spite of giving suprapubic pressure, the flexion is not achieved optimally. So in that at that time, I put my finger into the mouth, but of course, this may increase the risk of mandibular fractures. But as long as we know how much traction to apply, I think this should be okay. So in Burn Marshall technique, what happens is, so we once the baby's shoulder and the hands are delivered, so the assistant puts pressure in the suprapubic area or just above the at the fundus, and the baby's the legs, both the legs are held with the hand, and once the baby's head's flexion is maintained, we take it over, sweep it over the maternal abdomen like this. So this is by maintaining the flexion that we will be delivering the baby's head. So here the important thing is the traction. The traction has to be very constant, and it should be with caution. And the traction has to be towards the obstetrician, towards us in the beginning, and then the baby has to be swept over the mother's abdomen like this. So this is the Burn Marshall technique, and in majority of the cases, especially in vaginal deliveries, this is sufficient to deliver the baby's head. So if this is not possible, then we apply the forceps into the aftercoming head and try to deliver. but this is something which I have never done in my career. The third thing is the Marshall smelly wheat, smelly wheat MSV technique, wherein we put our finger onto the baby's face, and we try to press from the suprapubic area and maintain the flexion and bring out the baby's head. But this again is like, I don't find it to be necessary in many of the cases. I just gently put my index finger into the mouth and press suprapubically to maintain the flexion and try to get the baby's head out. So I will show you one more video which I have recorded. Yeah, so this is one more video. This is a 1-minute video which I will show you. So here, yeah, we are directly into the uterine cavity, and I incise the uterus. So I use an artery with the tip facing up, so that it doesn't poke anything. So most of the times the breech will be, this is the complete breech, where I just gently have to pull at the ankle to deliver the baby's leg. See, you can see here another leg is extended. So gently just pull it out. And here you can see that I'm trying to bring the back anterior and then delivering the baby's hands. So then I take the baby's body upwards. Here I have held only one leg, but ideally both the legs should be held. And then I put in my finger into the baby's mouth, because this is slightly a big baby. And then my assistant is gently putting pressure to flex the baby's head, and the baby's delivered completely. So here a couple of points which we need to note. I will replay it again just to make it a... So here, only once I have incised, I can see that one of the leg is extended and one of the leg is flexed. So the leg which is popping out, I mean, I have delivered it. The leg which is extended has to be delivered by traction at the inguinofemoral junction. We cannot just keep pulling at the other leg, and the rest of the body has to be delivered only after both the legs have been delivered. So here you can see that I have brought the so both the legs I have delivered, and the baby's stomach is facing upward. Never put traction onto the baby's abdomen, because it may compress or it may damage the abdominal organs. So the traction has to be at the inguinofemoral junction only and nowhere else. So here you can see that the stomach is facing upwards, but I am comfortable only when the back is upwards. So it is important to rotate the baby's body, though it is big, to bring the back anteriorly. And now you can see that the shoulder, one of the hands you can see now, which has slightly come out. So this hand I will sweep on the baby's face. So another hand also I have swept out. And here you can see my struggle with the delivery of the aftercoming head. So you can see the cord is already out, but I'm ignoring the cord, because I know that I will have to deliver the baby's head in the next few seconds. So don't bother about the cord. Don't really get panicky when the cord is out for more than like 15-20 seconds. It really doesn't matter. And now you can see that I'm struggling. I'm holding one hand, I'm holding one leg, and I'm trying to apply gentle traction. Here, this is wrong. You have to hold both the legs and then apply the gentle traction. I'm trying the Burn Marshall technique or sweeping over of the baby's body over the maternal abdomen, but that is not successful in this case to deliver the baby's head. So here you can see that I have put my finger into the baby's mouth, but still I'm struggling to deliver the baby's head because it's a big baby. It is a deflexed head, and the flexion of the head is not being possible in this case, even after my assistant is pressing. So in these kind of situation is where we get stuck and where we start panicking. So here you can see I have made up my mind here to increase the size of the incision, like convert the uterine incision into an inverted T, and I gave a last try. So with my finger into the mouth, so I'm gently trying to flex the baby's head and try to deliver. So one more thing that you can notice here is I have put my hand onto the baby's shoulder and then trying to pull, which is again, like, has to be done with a lot of caution, because this may cause clavicle fracture also with compression. So this is a video which I think everybody has to see to learn as to what not to be done. But then again, like, as long as we have enough experience, as long as we know what we are doing, and as long as we kind of have a control of our pressure and of our maneuvers, I think it is quite okay. So the ultimate thing, especially in a cesarean, when you are doing it as an elective procedure for a breech delivery, is to deliver an undamaged fetus. It is extremely, extremely important. And these maneuvers will help us in taking all the precautions and also in knowing what is the right thing to be done at that point in time. So after this, I think, yeah, the maneuvers are all over. Anything else, madam? I can't remember anything.
No, perfect, ma'am. The last video was perfect on how to bring it anteriorly, because that was the challenges you face at every position. So where should the traction be applied, madam, while delivering the fetus?
Yeah, this is extremely important. Don't pull any of the parts. See, you cannot pull at the baby's ankles or at the knee. The traction should always be at the inguinofemoral junction, and never shake hands with the baby. Always shake the leg. So don't, if the hand is trying to come out, which happened in my last video which I showed, there is a hand which is trying to pop out. So never ever try to pull the arm. Never do it. You always have to push the hand back into the uterine cavity and do the delivery as a standard procedure. And never apply pressure on the fetal abdomen. So this is not right. Always apply the traction at the iliofemoral junction.
Ma'am, when should the breech extraction be done, ma'am? When do you do a breech extraction?
See, I have done it only in one case, in a premature baby in twins, where the first twin had already delivered. In the second twin, it was in the transverse lie, and I had to do the IPV, like I had to put my hand completely inside the uterine cavity, and the baby was hardly like 1 kilo, and try to do the breech extraction. I have done it in only one case.
Okay, ma'am. What are the injuries that you have come across, or not by you alone, you have heard, or when babies get referred to our NICU, what are the injuries you have seen?
So I have had 2 times I have made a nick on the baby's buttocks. That's because of the thinned out lower segment. And I haven't had anything else apart from that. So I have heard that I have taken a poll. Okay, I will just share the poll with you. This was in our Bangalore group that we took the poll. Can you see, madam? Can you see this poll?
Yeah.
So this is what all we have come across in breech delivery, whether we have made a nick on the baby, caught hand instead of leg, couldn't extract the head easily, extended uterine incision, took long time for the baby delivery, extended hand which couldn't be delivered, or I have never had any problem, or I have had all these problems, but still I'm very confident of doing a breech delivery. So we had around almost 40-45 people who voted or who took this poll, and majority of them said that they are very confident in delivering the breech in spite of having these problems. And most of them had a problem of delivery of having trouble in delivering the fetal head. Okay, apart from that, injury wise, I don't think there is anything. I have seen one fracture of the femur, which was told to me by the neonatologist, and one dislocation of the hip, which was told to me by the neonatologist. But personally, I mean, I haven't had it because I think, yeah, I follow standard steps for the breech delivery.
Ours being a referral center, no ma'am. So we got when delivered outside and the baby shifted, same as what you told, more of femur fracture. So I think they're tagging on, like when you told, how to deliver it. It's very, very important. We find a lot of femur and clavicle fractures and dislocation, as you told. Then when, ma'am, you do IPV, what role of IPV? Have you done it, or what is the role?
Yeah, only in one case in the second twin after the delivery of the first twin. I mean, otherwise I don't do all these maneuvers. I'm still very comfortable doing a cesarean even for the second twin if I have to do it. But IPV, I mean, not really. In modern obstetrics, these kind of heroic things don't really have much role, is what I feel, because in modern obstetrics, because of the litigations and also because of the easier acceptability of the cesareans, I think we should keep all the other things, I think, as a academic purpose only. I mean, nothing for practical purposes.
What are the precautions you take during vaginal breech delivery?
So I have conducted 3 vaginal breech deliveries in my 18 years of private practice. So I wouldn't recommend anybody to go through this unless the patient is fully dilated. You are seeing the breech at the perineum, and it is like an average size baby with an adequate pelvis, and also it is a multiparous patient. So otherwise, even if the breech is at the perineum in a primey, please go ahead and do an elective cesarean. Push the breech up. We know that the breech can be pushed up, though it looks very tempting. We still know that there could be a rim of the cervix, and the head and the rest of the body is still high up. So don't do heroic things in your private practice. So I have done 3 vaginal breech deliveries. So all of them I have done it only in the middle of the night when I couldn't arrange for a cesarean within say 20 minutes to 30 minutes. And one of the patient was a top lawyer's wife. And it was like, very, very stressful. So here the baby's weight was 2.8 kilos, and it was a second gravida with a previous normal delivery. She was 9 centimeters when she came in. So what precautions I take is I empty the bladder completely. I give liberal episiotomy. I make sure that I have 2 assistants at all point in time when the breech delivery is happening. I don't interfere or pull or push anything till the baby is delivered till the umbilicus. And the rest of it, I follow the same standard maneuvers which I have mentioned here. Here in breech delivery, the most important thing is the space and the delivery of the baby's hands. So if the baby's hands are extended and if I'm finding it difficult to deliver the shoulders, so what I do is the Lowset maneuver, where I gently rotate the baby's body 180 degrees, and this can dislodge and deliver, and I can deliver the baby's head with this maneuver.
Yes, ma'am. This is what I wanted to ask you, ma'am. About 180 degrees rotation. You covered it. Wonderful. So, anything else you want to add, ma'am? I think all the questions have been covered.
So again, I would emphasize on the safety of your practice, and I think once we have a published data that planned cesarean is better than planned vaginal birth in frank breech delivery, I think there should be no doubt or no dilemma in you for convincing them for an elective cesarean. So I have had, even like just 2 days back, I had a patient with frank breech, wherein she came asking whether I would do a normal delivery for her at 39 weeks. I refused, and I told them clearly that no, I'm going to do an elective cesarean. So they were already like, seeing someone else. They said, only if you're going to do a vaginal delivery, I'll come to you. So I said, please go back to the same doctor, whoever has told you elective cesarean, because that is what I'm going to do. So there should be no doubt. about this point, that all breaches should be delivered by elective cesareans, because the flexion and extension of the head cannot be diagnosed with any of the imaging modalities, even if you have eaten or even if you have a HERA in your labor room. You cannot do it. And I wouldn't really suggest anybody to go through the trauma of baby's head getting stuck. So I think that's about it. And especially in term, unless unless you feel that the baby will completely just come out on its own. So yes, ma'am.
No, correct. Finish it, ma'am. Yeah. Ma'am, somebody's asked, in second gravida, with a 2.8 kg baby, can they allow for normal delivery? A breech presentation. Yeah.
If you know it's a breech, if you know it's a breech, if you know that the patient may go into labor anytime, please do an elective cesarean in your private practice. Please don't give a trial. Explain everything otherwise. Explain everything and take consent that there may be this problems at different stages. And if the patient agrees, which I don't think anyone would, so if they agree, then I think, yes, you can go ahead, but you will have to I think you will have to lose out at least 24 hours of your lifespan till she delivers a healthy and a good upcar baby.
Correct, ma'am. Wonderful, ma'am. The maneuvers videos were excellent. This is definitely, I think, many people will have to, before they even start a breech, the beginners, when they start doing breech, they should just view this videos of yours, and it will be very helpful. Wonderful, ma'am. Excellent.
Yeah. Thank you, ma'am. Thank you so much.
Thank you,
everyone. Thank you, sir.
Thank
you
you.
for listening to.
Thank you, ma'am. Thank you. Yes.